Here. All right, got it. And then let's see here. Um,
If you go to slideshow,
thank you.
Yeah.
Thank you.
It's
All
all
right, there
good.
we go.
There we
go.
go.
Is,
That
it,
looks
is that full screen now?
Yes, it is.
All right.
We do
So,
have a little dialog box in the bottom right-hand corner that says welcome. I don't know if you can move that dialog box.
oh yeah. How do I remove this? Start. Oh goodness. Hold on. Let's do this. All right. Slideshow. There we go. Is it gone?
Perfect.
All righty. So welcome everybody. Thanks for joining today. I know it's Monday, but thank you for joining to hear about cancer screening. Cancer screening is very important, because it can help detect cancers when they're in their early stages. In the earlier stages, cancer is usually treatable and curable. I know a lot of people, they think cancer is still this entity that's not curable. We haven't found a cure yet. But when it's in its early stages, stages 1, 2, 3, it's curable. The higher the stage, the less curable it becomes. So it's very important to detect these cancers at a early time frame. In the United States, the number one killer is actually cardiovascular disease, heart attacks. And that's because in the US in general, we're very overweight. A lot of us are overweight. We're not eating healthy. So that contributes to high blood pressure, high cholesterol, clogged arteries. And so in the United States, we actually die. Our number one cause is cardiovascular disease. But if you look at elsewhere in the world, the actual whole world, you look at places like parts of Asia, other areas, it's actually cancer. So actually, cancer overall is the number one killer in the world. But in the US, I mean, we're so well fed here that we actually end up dying from cardiovascular disease. But most of the cancers that happen, about 90% of them, are from what we inhale, eat, drink, things that we consume into our body. With enough damage to our cells, the DNA of the cells become damaged and they can actually form cancer. So I often get asked, what exactly is cancer? Is it an infection? Is it a virus? What is it? Cancer is actually when one of your regular cells, normal cells, is no longer able to stop its replication. So actually, almost all the cells in our body, they're constantly being reproduced. Old ones die, new ones are made. So it's basically an imbalance where the cells aren't dying off slowing up. We're making too many cells, so you get a tumor, overgrowth. And a lot of these cells, they just can't control their growth. They end up growing, and then they never stop. Whereas your normal cells, they know, hey, we've made 50 or 100 cells, we got to stop because it's inappropriate to make any more. We don't need any more. So that's what cancer is. It mutates and it continues to grow, and it can spread. So a lot of cancers, it can spread to the bone, the brain, other parts of the body. So it can be very scary to let a cancer grow. And if caught early, it's curable. But by detecting these cancers early, us men, we can live longer. So the ones that have screening recommendations in the United States for men are number one, prostate cancer, lung cancer, and colon cancer for men. These three are recommended for screening in the United States. If you look at Asia, like Taiwan, they actually have screening for stomach cancer. Stomach cancers are so common there that they do endoscopies to check for stomach cancer. A lot of it's due to a bacteria, H. pylori, but that bacteria does not really affect men in the United States as much. So there's very low chances of gastric cancer in the US, so there's no screening for it. So whenever they decide on what to screen for, they want to at least screen for something that's common. We don't want to be screening for some rare, cancer that nobody ever gets, wasting resources on it. So usually it's the ones that are very common and also ones that are curable. So there's no point in screening for a cancer if there's no cure for it. So these three cancers that, we're talking about today have good cures for it when they're caught in the early stage. So in terms of, what's recommended by the CDC, the Center for Disease Control and Prevention, In general, they recommend screening for women for breast and cervical, colorectal, and lung, but they don't include prostate cancer. Prostate cancer screening has been very controversial for us oncologists who see prostate cancer in its early and its late stages. We agree that we should be screening for prostate cancer. It spreads, and the worst part of prostate cancer is that it's slow growing. So when it does spread, yeah, it's slow growing. You can still live for years, but most patients are in pain. The cancer is spread to their bones, their liver. They're living in agony those last few years. So, getting treatment, it's a quality of life issue also. So more than just extending quantity. But some of these cancers, you really don't want them to spread out. So, there was a while where prostate cancer was recommended that it be screened. Then about 5-10 years ago, the US Preventative Task Force kind of looked at the pros and cons and said, hey, you know what? Nobody should be screening for prostate cancer. And a few years later, they backed up and they said, actually, you know what? We're noticing there's a lot more people dying from prostate cancer, getting metastatic prostate cancer. We should probably rethink about telling explicitly not to get screened for it. So now they kind of just put it on the responsibility of the physician. They say, hey, please talk to your physician about the pros and cons of screening. But there's certain populations where we highly recommend screening, and that's if you have a family history of prostate cancer. If it's an old person, older relative, yeah, but if it's a young relative, like somebody in their 40s or 50s who gets prostate cancer, then yeah, you should be screened early too, because there may be a genetic component. So 90% of cancers are that randomness from things that we eat, drink, inhale. The other 10% are genetic. So it is, even though it's a small percentage of the cancers, but still, genetic causes still, can lead to cancer. So yeah, and so basically in men, we see here the colorectal, lung, and prostate cancer. And another group that should be screened for prostate cancer is African Americans too. The African American group, we've shown in numerous studies that they have higher incidence of developing prostate cancer. And also more aggressive prostate cancer too, the type that grows quickly, doesn't respond to treatment, and spreads out. So very important to do prostate cancer screening in that group. So let's talk about our first cancer, colon cancer. This is the third most common cancer in the United States. So the colon is the last portion of our intestines. So, our GI tract starts, from our mouth to our esophagus, then to our stomach. Our stomach, secretes digestive juices, acid, starts digesting things. There's some absorption that happens in the stomach, but then we go into the small intestines, where things are further broken down. There's some absorption of liquids. And the last portion is the colon. The job of the colon is to, absorb nutrients, but also to dry out the poop too. So we found that when people don't eat enough fiber, there's a higher chance of colon cancer. And that's because, the poop is staying in the colon. It's staying there with toxins. It's damaging the cells in the colon. So having bowel movement is actually good. It's good to poop all that stuff out to help clean out our colon. So, I recommend, patients take Metamucil. It's a fiber drink. It's an orange powder. You drink it every night, and it helps increase the fiber content in our, GI tract and our diet. And it really can actually help prevent colon cancer. We've seen studies where we see, like in areas such as Texas, where, heavy meat eating, less fiber, that there's higher incidence of colon cancers in those states. Whereas, other states where, there's a high, fiber intake, there's actually less incidence. So, it's a very, very strong correlation, with fiber intake and colon cancer. The risk is 1 out of every 20 people. In 2019, there was about 100,000 new colon cancer cases just in the United States. And the rectum is right here. That's the last portion of the colon. It's right here. And that also further dries out the poop too. So as you notice, as the poop goes through the colon, it gets drier, and drier. And the more dry it gets, the more concentrated that toxin is. So that's why the rectum, it can also be subject to cancers too, because, that's where most of the poop has dried out. And, it leads to about 50,000 deaths a year. Okay. And most of these are preventable. So in terms of colon cancer, there's a progression from polyps to actual cancer. So if you look on the left, in its early benign stages, there's hyperproliferation where the cells kind of grow. Just it's like a little nodule. Then they can form these little polyps. These are growths, right? Remember we talked about tumors are overgrowth of normal cells, but in the benign stages, they kind of don't spread. But as it becomes more mutated, you can get what's called severe dysplasia. Dysplasia just means abnormal looking cells. And then finally they become malignant, become a cancer. Once it becomes a cancer, it can do things like spread through the bloodstream, spread through the lymphatics, spread through the lymph nodes. So, when we stage a cancer, there's 1, 2, 3, 4. In general, stage 1 is a small cancer. Stage 2 is usually a big cancer. Stage 3 is usually a cancer that's on its way to the lymph nodes. The lymph nodes are basically the body's filter system. So when cancer cells try to escape, the lymph nodes capture it. You can actually see lymph nodes start to grow, and expand. So a lot of these patients, when they're initially diagnosed, if there's some aggressive features, we commonly do a CT scan of the whole body to take a look, see if it's spread anywhere. Are there any lymph nodes involved? Is the liver involved? Are the lungs involved? So that's how we stage a patient. But we see this progression. So when they do a colonoscopy, every 5 years or 10 years, whatever program you're on, depending on your risk, they remove the polyps. They want to remove them because those are technically precancerous. They can develop into aggressive cancers. There's certain genetic conditions where patients develop polyps very quickly, and they develop a lot of polyps. And some of these patients we actually recommend that they actually remove their colon, have it removed, because the chance of it becoming colon cancer is so high. So risk factors for colon cancer: inflammatory bowel disease. What inflammatory bowel disease is, there's some patients with an autoimmune reaction towards their own intestines. So these patients have diarrhea, 10, 20 times a day. There's blood in their stools. It's basically their own bodies attacking their intestines. So whenever you have inflammation in the body, it triggers inflammatory markers. It triggers cells reproliferating, and that can, cause cancer. My best way of, kind of describing how a cancer forms is if you ever take a piece of paper or like any sort of, paper with text on it, and then you photocopy it, and then you take the photocopied product, you photocopy that again, and then you keep doing that. And by the time you photocopy 100 times, it's all mutated. The words are all bent over or whatever. So that's why, when you make copies, you want to have the original. Always make copies off the original. Don't make a copy off a copy, because there's always little changes here and there that add up over time. So, that's kind of how cancers happen. And with inflammatory bowel disease, that's basically what's happening. It's forcing all these copies to be made, and one of those copies are going to become malignant. Family history, if you have a family history of colon cancer, you're at higher risk. Genetic disease, lack of exercise, diet low in fruit and vegetables, a low fiber, high fat diet. So we know that fats, actually, there's a lot of toxins that we consume that are soluble in fat, meaning they stay in fat. So when you eat too much fat, although fats are good for us, we should always be having a little bit of fats. But you have too much fats, or fats from animals that have been around pesticides or other toxins, you consume their fat that has toxins in it. You eat that, and now that goes into your fat. Those toxins are in your fat now, because the only place these toxins go is in the fat. They're fat soluble. They don't stay in liquid components or compartments. So that's how fat can cause cancer. Being overweight, that just means you have a big reservoir of fat. Obesity, those are kind of pretty much the same. Same with alcohol. Alcohol, it's very detrimental to the body. I like having a drink every now and then, but I always try to limit it, because alcohol really affects every single organ in the body: the brain, the blood vessels, the heart, the intestines, the lungs, everything. Alcohol, we clean dirt and bacteria on our countertops with alcohol, and now we ingest it into our system. After a long time, that can cause damages to our cells that lead to cancer. Same with tobacco. You're smoking, it goes into the lungs. You have blood vessels in the lungs that absorb these toxins, and now it goes all over the body. We've seen tobacco cause higher chance of breast cancer coming back. We've seen it cause bladder cancer, because now when your body's trying to get rid of these toxins, you pee them out. So now these toxins are in the bladder hanging out. It damages the bladder lining, and now you can get a bladder cancer from smoking cigarettes. a lot of other toxins too, any sort of solvents, certain types of paints. So some of them are from work, so certain factories, you hear about, their workers getting cancers, but it's all from toxins that enter the bloodstream and then over time. So it's not just one-time exposure that causes it, it's numerous insults to the body that it can't recover from, that eventually causes cancer. So to prevent colon cancer, diet, take some more fiber. I think the easiest is to take Metamucil. I myself, I don't like eating vegetables, so I take Metamucil. Aspirin has been shown to decrease colon cancer. Multiple studies have shown that. Exercise, by exercising, you reduce the fat content in your body. It's good for your heart. Less alcohol. I mean, you imagine alcohol going through your system, GI tract, it's destroying everything in its path. And no tobacco. Like I mentioned earlier, there's a lot of toxins in cigarettes, not just the nicotine. I mean, nicotine, that's probably the least worrisome toxin in a cigarette. So they advertise these nicotine-free cigarettes, and that's no good. Who cares? There's still cyanide, a bunch of other things in cigarettes that haven't been removed. So don't be fooled by non-nicotine cigarettes. Symptoms of colon cancer, most commonly, is blood in the stool. What happens is these tumors form and they grow into the blood vessels. So normally blood vessels are all contained, but you have a tumor invading it, and also the vasculature in the tumor is kind of messed up, so it bleeds easily. So a lot of times, when a patient is worked up for anemia, meaning having low red blood counts, the first thing that goes in our mind is, hey, is there a colon cancer? Is there a cancer in the GI tract that's causing this slow bleeding that they're not even aware of? Oftentimes, the bleeding is so little that you don't really notice it until there's a lot. And then you can also, usually abdominal pain is because the tumor is kind of obstructing the lumen of your intestines. So when food tries to go through, it's just this extra stress in the stomach that doesn't feel good. So it's alerting you that, hey, there's something else that's going on in your intestines. The last one is unexplained weight loss. Patients often wonder, why am I losing weight from the cancer? Cancer cells are very metabolically active. They're actually probably more metabolically active than our regular cells. So they're stealing all our nutrients. So now our normal body, our normal muscles don't get the nutrients. It's the tumor that's stealing all that, growing and getting bigger and bigger and bigger and bigger. That's what can cause unexplained weight loss. So in terms of screening, it starts at 45 years old now. When I was in residency, it was 50 years old. So we see it's getting lower and lower and lower the age. And that's because younger and younger patients are getting colon cancers. A lot of them is just having a horrible diet, microwaving food in plastics and eating them. Even if your plastic container says BPA free, there's other toxins in there too that can cause cancer when they're microwaved. So don't be fooled by thinking you're safe by using a BPA free bottle or BPA Tupperware. There's other toxins in it. And even when your plastic says microwave safe, that just means it won't melt and implode when in the microwave. It doesn't mean that it's not giving off a bunch of toxins that you're going to consume that can cause cancers, leukemias, a bunch of different other things. So don't be fooled by some of that marketing. But we are seeing younger and younger cases of colon cancer. But majority of newer cases, they do happen in people over 50, but I think that's going to change. I think in 5 years, 10 years, when we look at the data, it's going to be probably 80%. Now there's more in younger patients. Okay. With medicine, we're always behind by 10 years, because these studies, they last over 5-10 years, and we get the results, so usually, I hate to say it, most of us were behind 10 years. And earlier screening, if you have risk factors, let's say you have a family member who is 45 and gets colon cancer, any sort of cancer that has a screening test for it, you should actually get screened 10 years prior to that. So if your uncle had colon cancer at 45, at 35, you should probably think about getting a colonoscopy to check for colon cancer, just to be safe. And if you have risk factors, like I mentioned, inflammatory bowel disease, personal or family history of polyp or genetic syndrome. And the next question is, do we stop at 75 years old? I don't think we should stop. The debate is that, hey, when you're over 75, you might die from something else, or you might be too old to go through the surgery and the chemo. But we treat a lot of older patients. We've treated a lot of patients for 80, 85 who beat it, who, if they didn't get treated, they would probably die within a few years. So I think it depends on the health status of the patient. A lot of people think, oh, once a patient's 90, you don't have to really do anything. Like, forget all the screening. But a person who lives to 90, they probably have a better chance of making it to 100 than I do. So I don't think it's reasonable to discount somebody because of their age and say, oh yeah, they're 80 or 90, forget it, we don't need to do it anymore. I think it really depends on the patient. So the easiest screening is a stool test. The stool test is looking for blood in the poop. Because like I said, you shouldn't have blood in the poop, but if there's a polyp, if there is a cancer, then you may have blood in the poop. Although there's other reasons why you might have blood in the poop, but usually if you have blood in the poop, it's because of a GI cancer. So the first test is a flexible sigmoidoscopy, but this only examines the last portion of the colon, not the whole thing. A colonoscopy will examine everything. And then now we actually have a non-invasive approach, which is called CT colonography, where it's actually basically just a CT scan that we do. The bad thing about this is it can't detect tumors that are less than 5 millimeters. And also, if they do detect something, they can't remove it or biopsy it. Whereas a colonoscopy can. A colonoscopy sees everything. If you do your bowel prep properly, you pooped everything out, it's going to see all the colonoscopist will see all the polyps, see all the cancers. We'll be able to remove suspicious lesions, biopsy them, send them off the path, and determine if it's cancer or not. So the best one is still colonoscopy. But for those who are afraid, a CT colonography can be entertained. So this is a yearly stool test, pretty easy. There's these kits, they have you poop on a piece of paper, then there's like a little spoon, you put the specimen in, and then you return it to the lab. And usually within a day or two, you get your results, and they'll tell you if there's any blood in your poop. So this is the flexible sigmoidoscopy. So if you look at the figure on your left, this black little slither thing, that's the scope. Okay, that's the scope. And on the right, you see how the colonoscope goes entire. It goes up the descending colon, through the transverse colon, down through the ascending. So this examines everything. So flexible sigmoidoscopy, only checks the lower 1/3 of the colon and rectum. We do it every 1 to 5 years, or we do it every 10 years with the FIT blood stool test. But then you got to do the blood stool test every year. The reason is the left side, or basically what you're looking at right here, the farther portion, the right side, which is on this picture to the left, those tumors commonly bleed, so even if the flexible sigmoidoscopy doesn't go all the way into the other side, if there's some bleeding from a tumor there, it'll catch it, so that's but then you got to do it every 10 years with a flexible sigmoidoscopy. So I think if you're going to go through that, I think a colonoscopy is better. You can just check everything. Colonoscopy, one benefit is it can remove polyps. The recommendation is every 10 years. But if you get it done and they find little polyps or something irregular, they may have you come back in 5 years or 1 year or 2 years, depending on how worried they are. And the last one we talked about is the CT colonography. They can't do biopsies, and it's every 5 years. So you don't get to do it every 10 years, every 5 years. And then there's other things, that they have out there, like the capsule endoscopy, where you swallow this little pill camera, it goes through your intestines, and then you got to make sure to catch it in your poop. But that is also like a non-invasive way of doing a colonoscopy too. Patients who get earlier screening, if you have a close relative who's had polyps or colon cancer, and these other things we talked about. With colon cancer, very high cure rates when it's detected early. Stage 1, 94% survival rate. Stage 2, 82%. Stage 3, 67%. And stage 4, it's about 11% long-term survival rate. Stage 4 is generally considered not curable. But the chemotherapies for colon cancer have gotten so good over the past 5 years that they're able to extend the life of patients even when they're in the stage 4 category. The treatment for colon cancer primarily is surgery. You have to remove that portion of colon, reattach it. Sometimes patients may even need a ostomy, which is where they poop into a bag. So depending on the case, sometimes they're able to reverse it, sometimes they're not. After surgery, then we can tell what stage it is. We could see how deep the tumor was invading the wall of the colon. We can see if any lymph nodes were involved, and that helps us stage the patient. And usually we offer chemotherapy to help prevent the recurrences of the cancer. And for colon cancer, there's all these special genetic tests now, so they can see if what you'll respond to, what meds you won't respond to. So chemotherapy has also come a very, very long way for colon cancer. It's very tailored now. And in rectal cancer, the last portion of the colon, we often combine chemotherapy and radiation first to shrink down the tumor, and then we follow with surgery. The benefit of doing that is, some of the rectal tumors, they're very close to the anal sphincter. So if you directly operate on them, you may lose your anal sphincter. Now you have to have an ostomy for the rest of your life. So by combining chemotherapy and radiation, some of these tumors we can shrink down, and we can actually allow patients to preserve their bowel function. They get to keep their sphincter muscles down there. The next one is lung cancer. So who needs screening for lung cancer? Not everybody needs screening. If you're a never smoker, you don't need to go through with this. But it's very specific on who they recommend it for. And it's somebody with 20 pack year or more smoking history. So what's a pack year? The way we do it is we take the number of years you've smoked, let's say 20 years. And if you smoke 1 pack a day, you multiply it, and that's 20 pack year. Let's say you smoke 20 years, but you smoke 2 packs a day. That's 20 times 2. So then now you have a 40 pack year history. Okay, so 20 pack year doesn't mean 20 years of smoking history. I mean, if you smoked for 5 years, but you smoked 5 packs a day, that's a 25 pack year history. So that's a patient that shouldn't get screened for colon cancer. And also a current smoker, or if you've quit within the past 15 years, and you're between 50 to 80 years old. The risks of doing screening, there may be some false positive, there may be some overdiagnosis. And with the screening, it's a CT scan, and there's always a risk of radiation exposure. Although it's low, a CT scan, I mean, yeah, there is some exposure, but it'd be very rare for the CT scan to be causing a cancer in an adult. Usually the people who are most sensitive to radiation are kids, or people in their teens where the tissue is developing. Then it's very susceptible to that DNA damage and mutation. But most adults, a CT scan should not be really increasing their chance of any bad outcome. Lung cancer symptoms: coughing that gets worse or doesn't go away, chest pain, shortness of breath. The shortness of breath is sometimes these tumors grow so big they're blocking the airways. You can't get enough oxygen. And coughing up blood. Coughing up blood is always abnormal. It should prompt a workup for lung cancer in a smoker. People who feel very tired all the time. And this is kind of the same thing I talked about when people lose weight. It's these lung tumors, they grow so quickly. They start stealing the nutrients from the rest of your body. So you constantly feel fatigued because the tumor is using up all your energy sources. And same thing, weight loss with no known cause. They can cause weight loss too. And in our patients, the ones that lose weight towards the end, they're usually the ones that do the worst with treatment. It shows you that the cancer is very aggressive. When should screening stop for lung cancer? So, they say, hey, once you've turned 81 years old, you could probably stop screening. Or if somebody has not smoked in 15 years, because the thought is, hey, if you quit 15 years ago, you haven't gotten lung cancer, died from it right now, you probably don't have lung cancer. Although, I would think it's too different. I know some patients who probably still could develop one 20 years after quitting. Or you develop a severe health problem that you're going to die within a year, then there's no point in getting screened for it, because you have other competing health causes. Although lung cancer, I've seen these stretch out for 3-4 years. So even if you had it had to be a very severe health problem for you not to be screened for this. How do you reduce the risk of lung cancer? Don't smoke, avoid secondhand smoke, and get your home tested for radon. So radon is actually a radioactive material that's in some homes, some areas that we breathe in. It can cause lung cancer in non-smokers. So only 10% of smokers actually develop lung cancer, but 90% of lung cancer causes are from smoking, though. But besides lung cancer, there's so many health detriments to smoking cigarettes that you're better off not smoking. In terms of treatment, there's surgery for early stages. If it's later stage, then it's kind of like colon cancer, where we do the surgery first, remove the main tumor, and then give chemotherapy to prevent it from recurring. So if it's gone to the lymph nodes, if it's really big, there may be indications for chemotherapy. Chemotherapy, like colon cancer, they've also very, tailored and personalized the treatments for the chemo. They run all these genetic tests on the tumor. They could see its actual, biological genetic profile and actually determine which meds are responsive, to this type of cancer. There's certain lung cancers. There's one type I can think of that it's commonly in Asian women who are non-smokers, and there's a certain mutation that's very responsive to medication. So in those cases, even if it's stage 4, their life expectancy is anywhere to 3 to 5 years, which is amazing, because usually lung cancer, if it's stage 4, life expectancy is about 1 year or less when it's stage 4. But if they can figure out which targeted mutation you have, they can target it. You take a medication that targets that specific mutation, and the results are actually quite good. Patients can live years. And radiation is basically high-powered X-rays directed at a tumor that actually kill off the cancer. So some stage 1 early cancers, we can actually do radiation instead of surgery. My grandma, she recently had a lung cancer in Thailand, and the surgeons there were all recommending surgery. I suppose it's because she went to one of the most expensive hospitals in Thailand, where they just want your money. They want you to get the surgery done so the surgeon can make money, the hospital can make money. When I heard about the case, I said, no, I think this case is way better for radiation. So they went back and they said, no, our cousin in the US says the radiation is a perfect treatment for this. And now she ended up getting radiation therapy, and she's almost a year out with no signs of recurrence. So radiation is becoming more and more popular. It's a non-invasive treatment. And it spares the patient surgery. Grandma's 85 years old. She doesn't need to go through removing a lobe of her lung and being in the ICU for 2 weeks, risking getting sepsis, risking, getting infections, so radiation has become an amazing alternative treatment to surgery. So how do we design a radiation plan? The first step, I'm a radiation oncologist, so I like sharing this, but we do a special CT scan and map out the body, where we can actually see exactly where the tumor is. We actually see how it moves too, because when we treat a lung cancer, patient's breathing, right? So we can't just treat one area. We got to treat the whole movement. So by doing what we call a 4D CT, we actually track the movement. When we treat that whole area to make sure we get the tumor. So here it is. On the most left is if you were to just treat in one time frame. On the most right, figure C, that's the trajectory of the tumor. So we see it's moving. So if I were to just treat in one location, I'd be missing. So I use the image to the right. I treat that whole strip to make sure I get the cancer completely so it doesn't grow. And this is how we evaluate the plans to make sure they're safe. Every organ is a different color. So we can see that on the x-axis, the dose, the y is the volume. So we make sure that tissues aren't over-radiated. The way we do that is by drawing out every single organ, and our dosimetrist does that, and then evaluating how much radiation dose is. So by doing that CT scan, we can really personalize the radiation treatment to the patient. So every patient radiation plan developed is personalized to the patient. It doesn't work for anybody else. And this is a linear accelerator. This is what we use to deliver the radiation. These machines are anywhere from $3 to $5 million. They're very, very fancy equipment. So even with radiation, there's a new type of, it's been around for almost over 10 years. It's called radiosurgery, basically stereotactic body radiotherapy, where we actually shoot high doses of radiation at a small little tumor. And the beams are very conformal. It's pinpoint. And the results are excellent. We do it from brain tumors. Sometimes brain tumors are too deep for us to do surgery. The surgeon can't remove the tumor without damaging the brain. So we can actually use radiation to treat these tumors to halt it from growing, and outcomes are very good. So patients who are old, who are very sick, can't have surgery, we can use radiation to halt the growth of these tumors. So this is just a study. They looked at lung cancer. They're treating with this radiosurgery, SBRT type of technology. And they found that, the local control was, 88%, close to 90%. So it's very, very effective. It's just showing how effective these treatments are. The last one that we want to talk about is prostate cancer. So prostate cancer is one of my specialties, treating it for 15 years. It's very common over the age of 50 years old. It's usually slow growing. The biggest risk factor for prostate cancer is number one, being a male. Okay, you have to have a prostate to get prostate cancer. Number two is age. The older we get, the higher chance of us getting prostate cancer. They've done autopsy studies. By the time we're 60% of us have prostate cancer. By the time we're 70%. If we live to 100, we're all going to have a little bit of prostate cancer in our prostate. There's more than 3 million cases per year in the US. So yeah, it's very, very common. Symptoms include trouble urinating, frequent urination, decreased force of urination, difficulty starting or stopping the urine stream, blood in the semen, pain or discomfort in the pelvic area, and bone pain. In its late stages, when it's spread, it can cause bone pain. In terms of diagnosis, of the common exam that we do is inserting a finger into the rectum to feel if the prostate gland has any tumors or not. But that also takes skill. That took me years and years of training, and even as an attending, to really do one properly. And I think most people who do a digital rectal exam, they're not doing it properly. They don't really know what they're feeling for. So the best blood test is a PSA blood test. So with the PSA, it's a simple blood test. If you don't want a digital rectal exam, at least get the blood test. It's best to get both, because there's some prostate cancers that don't make PSA, but you put your finger in and you feel, oh, there's a big tumor there, and the PSA is normal. Those ones are actually the scary ones, the ones that don't make PSA, because the cells are so mutated, they don't make PSA anymore. So, but usually the PSA, you'll probably get the majority of the prostate cancers, about 80 to 90% of it. But that extra 10%, you probably need a rectal exam to really make sure you feel it. And usually we do an ultrasound, and it's a small probe that's inserted into the rectum. And then using ultrasound, we can actually do biopsies of the prostate. We sample 12 different areas to find out, where the cancer is. So, it's called a transrectal ultrasound guided biopsy, where, if the PSA is elevated, we do that to check. But now we've gotten even more fancy. There's also MRI. We use MRI to detect prostate cancers, because some prostate cancers are in the front of the prostate. So the ultrasound, the biopsy, they only sample the back. So I've had patients who come to me every single year, their PSA is going up, and they say, oh, the urologist took biopsies, there's no cancer. And then you do an MRI and you find, oh my goodness, there's a huge cancer in the front of their prostate that they've been missing. So, the beauty of doing the MRI is you get a full, complete picture of the prostate to detect if there's any other cancers anywhere else in the prostate. So with treatment for prostate cancer, there's surgery, which requires removal. Then there's side effects like incontinence, leakage of urine, nerve damage, impotence. So multiple studies have shown, the survival rates between surgery and radiation are pretty much similar. So a lot more patients are actually getting radiation these days. The other one is just to observe it. This is medication, not mediation, medications. So there's medications to control prostate cancer. So prostate cancer actually grows by the man's testosterone. So the more testosterone in our body, you can make these prostate cancers grow. So by taking medicines that block testosterone, you can actually control these prostate cancers. But most men, we don't want our testosterone blocked. It leads to weight loss, depression, weakened bones. So oftentimes these medications aren't a good long-term answer. Eventually, if some of these medications stop working too after a few years. And the last one is observe. If it's a low-risk prostate cancer and a patient is elderly, and you've done an MRI, you can confirm that he doesn't look too aggressive, then you can observe it, follow the PSA. The PSA increases to a worrisome level, then you can initiate treatment at that time. Okay, so a lot of these low-risk prostate cancers, we're observing these days. So yeah, this is a study looking at surgery versus radiation from the Cleveland Clinic, and they found very very similar overall survival rates between radiation and surgery. So the surgeons come out with their papers, they say they're 1% better. The radiation oncologists, we come out with our studies and we say no, we're 1% better. But really, on the whole, nobody can say one is much better than the other. Everything shows it's probably very similar in terms of survival, long-term survival between radiation and surgery. So here, another study from the Mayo Clinic looking at cure rates between surgery, radical prostatectomy versus radiation plus hormones versus radiation. And, it's all, these are in high risk prostate cancer patients. And, the cure rates were very similar. With radiation, there's definitely a better quality of life in terms of the study was done by Medicare. Patients who have to wear pads, for urine leakage, 30% of patients after surgery have to wear, usually it's temporary. A lot of them gain their function back after a few months. Radiation and 7%, I think that's too high. I think usually in my patients, it's 0 to less than 1% chance of them having leakage. It's very, very rare with radiation. In terms of impotence or potent in terms of sexual function, it's much less with surgery, around 11%. With radiation, men preserve their erections better because there's no injury of the nerves. So you can see, to preserve sexual function, radiation is a bit higher. One negative is there's more frequent bowel movements. So the reason being is the prostate is right in front of the rectum. So the rectum does get a little bit of radiation, does get irritated. So some patients can have diarrhea for 6 months to a year after the radiation. But usually in most patients, it calms down afterwards, usually by taking a probiotic. I definitely recommend probiotics to patients who get radiation to the pelvis. Probiotics can really, really help, restore the natural flora of the intestines and make bowel movements more normal. So in conclusion, with early cancer screening, most cancers, and we can extend how long we live. Then the next step is to watch what we eat and not die from cardiovascular disease, which usually that is what gets us, is the heart just gives up. But we can preserve the heart by eating healthy, exercising, not smoking, and screening is simple and usually very safe. So I know men, we don't like to talk about screening. I mean, even for me, goodness, I mean, I'm almost 45. In a few years, I'll be needing a colonoscopy. I never thought that time would come this soon, but yeah, it's something that I'm considering to do in a few years. I had my PSA check this year. It's normal. I not a big smoker, so those are things that I'm doing to keep myself from developing cancer. So even now, I'm putting a big emphasis on my health. I've been going to the gym a lot more now, exercising, eating right, because I turned 40 this year, so it's no more partying and drinking for me. It's time to really take care of my body. Okay. So yeah, so that's my talk. Anybody have any questions from the audience?
Well, first off, thank you so much, Dr. Yeh. You have such a personal approach to presenting, in addition to all of the empowering information you share, and we just really appreciate that personal touch. I know that screenings were really down during the pandemic, so this information is so essential, and cancer is such an out of control experience, but screening and these kind of proactive steps are within our control. So really appreciate that focus.
Yeah.
I want to invite people to unmute themselves to type questions into the chat. One question that I thought maybe you'd have some insight on are just like access to screenings for people that maybe don't have insurance or maybe don't have a medical provider. Do you have any thoughts on how they might be able to access screenings for cancer?
Yeah, so there are a lot of free prostate cancer screening programs out there. I used to, when I was up in Bakersfield, we had one where like every year we would do a free prostate cancer screening. If you don't have insurance, you can look into getting, applying for Medi-Cal, applying, there's always ways, to get screening. I'm hoping I can work with you guys to do a prostate cancer screening program. I know it's kind of late, but You know, I've worked with labs, a lot of labs, they're happy to do screening tests because they know it's helping, you know, men, it's helping the community. But yeah, you know, I would probably, you know, try to look for, you know, government sponsored stuff, but you know, usually they may be slow to respond, you know, getting Medi-Cal and all that. But yeah, I mean, there's always, you know, prostate screening fairs, but you know, things like colonoscopies and CTs for lung cancer, those are expensive, you know, so you know, you have to find some sort of government sponsored program, you know, and then, you know, it's covered.
Wonderful, thank you.